This is Matt Stevens, and I will be reviewing speech and swallow rehabilitation following partial glossectomy. The incidence of tongue cancer is 2.3 per 100,000, with 666 new diagnoses reported in 2010 in Australia. In Australia, the 5-year survival rate is highest for people with oral cancer compared to other head and neck cancer groups, meaning these patients are surviving the longest with speech and/or swallow dysfunction. The treatment of choice for oral tongue cancer is surgical excision of the tumor and the surrounding margin of tissue, known as glossectomy. A partial glossectomy involves removal of a segment of the tongue tissue, and in this article refers to removal of tissue within the anterior 2/3 tongue and not the tongue base, which is within the oral pharyngeal area. There are two main interventions after partial glossectomy. The first, dysfunction in speech following a partial glossectomy, arises from altered articulation and change in mid-sagittal grooving, leading to a perceived reduction in speech intelligibility. The second, dysphagia, results from reduced bolus control and manipulation in the oral cavity, which impacts on swallowing efficiency and increases the risk of aspiration. 4 studies reported speech intervention. All 4 studies described articulation training aimed at developing new movement patterns in order to compensate for altered tongue structure. 2 articles combined this with tongue and jaw range of motion exercises. The current literature lacks reliable evidence for therapy methods or techniques investigated and currently is insufficient to guide current clinical practices. No randomized controlled trials or controlled single-case experimental design studies investigating SLP intervention following partial glossectomy have yet been published. Due to the small number of intervention studies found, all study types from all years were included to review trends over time. This meant studies low in quality or level of evidence were included and are discussed below. In a specific study conducted to evaluate the speech intelligibility of patients undergoing total, subtotal, or partial glossectomy before and after speech therapy, 27 patients were used in the study, combined of 24 men and 4 women ranging from ages 34 to 79 years old. This study was designed into 3 groups based on the extent of their tongue resection. Different phonological tasks were recorded and analyzed by 3 experienced judges, including sustained 7 oral vowels, vowels in a syllable, and the sequence vowel-consonant-vowel. The intelligible of spontaneous speech within a sequence story was scored from 1 to 4 in consensus. All patients underwent a therapeutic program to activate articulatory adaptations, compensations, and maximization of the remaining structures for 3 to 6 months. The task was recorded after speech therapy to compare mean changes, analysis of variance, and Wilcoxon tests were used. Speech therapy was effective in improving speech intelligibility of patients undergoing glossectomy, even after major resection. Different pre-therapy abilities between groups was seen, with improvement of speech intelligibility in groups 1 and 2. The improvement of speech intelligibility in groups 3 was not statistically significant, possibly because of the small and heterogeneous sample. In conclusion, there have not been enough well-designed studies over a period of time to determine the most reliable evidence for the best therapeutic treatment for both dysphagia and intelligibility.